our penultimate speaker is Gregory Crawford. So we've gone from Anne Gregory to Gregory Crawford. And then we have an impressive speaker coming up too. And she'll be talking to you later, obviously. So,
thanks very much.
Please.
Thank you. So I'm delighted to be here, and at the introduction, Dorothy talked about the ends of life, if you heard just a little mention. And usually when we talk about death and dying and end of life, we're usually the last presentation. And so it's quite novel for me to not be in that position. And I hope by the end of my talk you might actually have my worldview that we are the centre of the care and that it's a huge problem and that it should be embedded much more than just at the ends. I'd like to acknowledge some of my researchers who are here, and this builds on a bigger body of knowledge looking at the issues for people with chronic, end-stage, advanced illness, and we've looked at policies and end-of-life policies and chronic disease policies, and hardly been not surprised by the lack of interface or that the answer to every chronic disease is refer them to specialist palliative care, which is not going to work either. We heard some talk about complex systems, but I might even suggest that chaos theory has quite a lot of things to assist in our assessment and analysis. Last week in The Age there was an article or a comment written by an intensive care specialist, a head of a large service, who found himself sitting by the bedside of his elderly father who died. And he talked about finding it hard to be heard, finding that it was not easy to be the one who was trying to advocate for a less active role, that doctors involved in his care were not accessible, that they weren't asked until the palliative care team turned up and then suddenly they were on the white chargers saving everything. But in hindsight, he described a man who had a very predictable chance of moving quickly from living, because he was living, to rapidly dying. And I think that's one of the big challenges for our health system, and that it is possible, although not necessarily easy, to identify a whole lot of these people. Prognosis is crystal ball stuff. You know, I spend a lot of my time as a palliative care physician talking or trying to answer the question of how long have I got, or describe what might be coming. And that's an inherently difficult conversation on many levels, at least being the scientific basis for the conversation, let alone the emotional content of it. But there are well-validated tools that will help us predict. And this story, if you read it in The Age, had a man who'd had several falls, and the fall was precipitation to admission, that he had a mild dementing illness, that he was frail and losing condition, and he would have ticked all the boxes on many of the tools that I'm going to mention today. So the statistics are that more than 50% of Australians die in public hospitals, so it's a large percentage. And not all of that is unavoidable, inappropriate. Some of it's by choice and some of it's by systems and the way they work. But there are significant differences between different countries. And so Australia is 54%. In England, Wales and Ireland are somewhere between 56 to 58% of their population die in their acute hospitals. And we are looking at the NHS for a lot of the things that we're thinking about implementing. New Zealand, the rate is 34%. So what drives that? Why is there such a big difference? And then when you look at an acute hospital inpatient system and try and assess what is the percentage of unmet end-of-life approaching palliative care need, so that sort of concept, there are widely differing rates, and there is certainly studies that have been done in large centres in the United Kingdom showing that at least 36% of patients sitting in an acute hospital on any one day have a whole lot of unrecognised approaching end-of-life needs. One major hospital in Auckland was studied recently, it's been published, and their rate was only 19%, so big differences. Now what drives that? And so, you know, we know a lot of the answers. You know, Transforming Health has some really clear guidelines. There's been a whole lot of research. The Australian Commission on Safety and Quality has looked at end of life in acute hospitals, and they've made recommendations. Health Performance Council has looked at improving end-of-life care. And I would suggest there are a whole lot of examples of innovative projects that are, some of them are implemented, some of them are presented, some of them are in partial development. And there are some good ones and some perhaps not so well-structured ones. But a lot of it's isolated and fragmented. And it's how do we change the system, and that's what Transforming Health is trying to do. And so I've focused my talk today thinking about the acute part of it only, because that's the part that Dorothy says we've got control, we've got levers to move it, and we all acknowledge that it's much bigger than that. And you know, I'm a clinician who actually works in the community. I do home visits as well as hospital visits, and I work in subacute and acute systems. But we have to start somewhere, and it's a big problem in the acute system. And all these frameworks have similar sort of rhetoric and similar goals and aspirations. And so what do we need to know? I think we need to understand what the current South Australian situation is, because we have an opportunity to be, because nobody's doing it well in Australia, so we want to be the head, we want to show them how to do it best, surely. What's driving it? What are the issues? What do our patients think? What do our clinicians think? What are the skill gaps? And I've certainly got a lot of ideas and thoughts about it, and a lot of these reports suggest some of these things too. And then as a person embedded in specialist palliative care, where do we fit in, and what use are we anyway? What do our generalist colleagues think? You know, there's a lot of rhetoric about end of life being everybody's business, but does everybody want to do it? And I suspect the answer is no, because it's not easy. And there's been a lot of work in our state about advanced care directives, and more recently within the acute sector around 7-step pathways. So, what do I think we need to do? Well, there is a well-validated methodology that's been used in New Zealand and the United Kingdom, and I've started a small unfunded project that's a pilot that's going to happen in the Royal Adelaide based on some of this, but I think there's a bigger project that we would like to implement. And what we want to really look at is a cross-sectional survey of the 3 main hospitals, the acute hospitals in our current change process. So Royal Adelaide, Flinders and Lower Mac. And a case note audit where you implement a prognostic tool, and the most obvious ones are the SPICT from Scotland or the Gold Standards Framework from the United Kingdom. They're very similar prognostic indicators. They look at indicators of frailty and then comorbidity and things that help give you a chance to say, look, this person needs further look. Look at their reasons for admission, the socio-demographics, comorbidities, and whether there's been any recognition that this person is likely to be approaching the end of their lives, and or whether they've actually started to implement some of those things. Then I think we need to have some patient and family interviews, and there are certainly validated service use questionnaires that would help unpick some of the issues that are specific for patients and the carer as a unit. And then looking at clinicians as well. Now, some of this similar work has been done in the United Kingdom, and what they found was that there was a large unmet need, that when you talk to the clinicians, their assessment was about 1/3 they recognised, so there was a large gap. So what can we do about that? So we've got 7-step pathways coming, we've got a whole lot of work on advanced care directives. I think the audit would actually see how much of that is actually in our systems. I think we'll find that there is a lot of incompletion and ad hoc basis to it. And then the other part of work that's happening in South Australia is the Minister of Health has put some money into general practice to look at partnerships with palliative care, which is really in the community sector more. But I think we need to be looking at embedding triggering assessments into care at the front door, not just when we think about it. 7-step pathways that I've seen talk about having a trigger and then a conversation, and the trigger has to happen automatically. It can't be reliant on somebody having the light bulb and saying it's got to happen. And we know that doctors generally are very poor at being the triggers, and you need to embed it into a system so it happens and somebody's being held to account for why hasn't that bit of paper been done. Some of the other things I'm sure we'll find, and other studies have shown, is that clinicians have difficulty with conversations. I spend a large amount of my academic time teaching medical students about communication, and yet they get out into the real world and some of their mentors maybe not quite as good anymore at the communication, or they've, as I found on a ward round the other day, and it's very strongly shown in the literature, that the care of the dying and the not curative patients become the job of the baby doctors in the system, and that's not a reasonable way of running our care either. And so that these senior doctors need to have hooks to make them improve their skills in communication, and there needs to be some hooks in the system to help clinicians maintain and have knowledge about end of life, of recognising it, of knowing how to talk about it, and knowing also the drugs and the other things that are easy that you might do if you're at end of life. So I think there are some ways that we could make them mandatory, perhaps. So I would hate to think that I had to do the mandatory communication skills and feel about it the same way I do about the manual handling that comes around every 12 months, or even the CPR sort of practice that even I have to do. But I think we need a baseline, and that's what I'm proposing for this. And then we've got some implementation, some actual interventions that can occur, and then it would be fairly easy to measure some of them as they become embedded into routine practice and become part of our new computerised patient management systems, hopefully. And so there's a whole lot of other gaps and things, but I think within the acute sector this is an opportunity to try and actually quantify the problem, to identify the people. And I'm sure that if we find these people earlier, then some of them may not come back into the acute sector, or may well find themselves in other parts of the system which may well suit them better. Okay, thank you very much.
Questions? It's interesting how people who have come up here to talk have been able to link to previous speakers and ideas. So that's nice, but is there any burning light up the back? Thanks. And then we have one down. Julia after that. Go on.
Thanks for the talk. My name's Arthur Brorsman, intensivist, so I can appreciate with the age article, and I guess you kind of know where I'm coming from with some of my comments that I make. But just some observations, if you can sort of kind of help me out how we can better measure some of this. And 150, 200 years ago, if you had gangrene, you were palliated because you knew you were going to die. 100 years ago, if you had a penetrating injury to the abdomen, you were palliated because you knew you were going to die. And 50 years ago, if your heart stopped, you were palliated. Well, if you got into cardiogenic shock, for example, you were palliated because there was no way you were going to survive. All those conditions are eminently treatable nowadays, and with the technical expertise just flourishing, it's harder to define those endpoints. And I think often we do leave it to senior people, to juniors, to do that and have those conversations. And they have difficulty not because they don't know the language, I think, but partly because they feel insecure and be able to identify those points. I think we've come to a point in time where we need to kind of case manage death. I don't think any particular silo of specialists can be able to fully identify when someone's coming towards the end of life, that little cut-off point. Often patients bring it to us and that makes it easy, but as specialists I think we struggle. And certainly as an intensivist, I find that about 10% of my consults or more, when I'm going there to patients who have acutely deteriorated, I leave with an NFR order being written up. So how do we kind of better case manage palliative care? How do we make palliative care more responsive in a sort of acute setting which is much more much rapid paced than what it used to be?
Thank you. And one of the suggestions is putting palliative care on a MET team. Well, in fact, there's research and evidence that shows that MET teams actually downgrade acuity of interventions and are actually often the people who are changing the goals of care, where those goals of care conversations should have happened, you would hope, before you got to that. But essentially, it's not easy to say that we are now in a palliative phase necessarily. You mentioned things that were clearly death confirming when they occurred, 100 years ago. But when somebody comes through the door of an acute hospital, you expect that you're going to do something, or there is a period of uncertainty. But some of the time it's the family are already there and we haven't got the skills or asked the questions already, and we haven't actually explored what the values are and the picture that happened in the 2 weeks, the 2 months before they came through the door. And that's something that we can correct. But also there is a period of undifferentiated care where it's not sure whether it's going to be better or worse. This week I saw a piece of research about some patients with COPD who all had non-invasive ventilation, and just before they were discharged, the researchers thought they were going to talk to them about end of life and future care options, and all the recommendations are that's the better time to be talking about would you go to ICU next time. And they all saw themselves as living people and all saw that acute hospital was the right place for them to be next time. And that it was really hard to open up a conversation to say what the implication of having had one episode admission for COPD, let alone having an admission with non-invasive ventilation. So I think you do need senior doctors. It's not just that junior doctors don't know how to have the conversations. You need to be senior to be actually able to stop and say, let's paint the whole picture and get collaboration and understanding from a family that the right action is not to be active. It's much easier if you're a junior doctor and you're thinking about your hierarchy or what you need to do. You work with systems, and active is the default response. And so you need senior doctors who have the skills, and senior clinicians, not just doctors, it's the whole system really, to be able to change that.
I have a question.
I sound like I'm preaching already.
Hi, it's Julie. Thanks, Greg, for this this discussion. I'm referring to your abstract, not to what you particularly touched on here, but just the issue around the cultural differences in how you will go about looking at this and addressing those conversations. And I guess you've partly drawn on that already with your discussion around the importance of having senior clinicians perhaps involved or some oversight in this. But you did mention stakeholder engagement with Aboriginal and Torres Strait Islander peoples and culturally diverse populations, and so I was just wondering if you could touch on a little bit about how you need to adapt and take that into account.
Well, I think, in terms of the methodology that I described, I didn't expand on really the stakeholder part of it, but patients, carers, clinicians, we are all really stakeholders and we are all consumers of the system, but I think that you need to actively look for the vulnerable groups, and vulnerable groups are certainly our Indigenous populations, our non-English speaking, but people who are approaching the end of their life, people who are sick are vulnerable as well. And you need to be able to hear those voices and put it together in some form. So, but I think equally you need to have some quantitative numbers or points in care that make people do something, as well as having the qualitative understanding of what it means for people. And to have a conversation about the limitation of treatments, or just because we can, should we, is by itself, it needs to be handled sensitively. I hear so many conversations when I meet somebody who is at a point where they've had the conversation, you need to meet the palliative care doctor. That's a very black line and a very hard conversation often for a referrer. They tell me about the time they were diagnosed with the metastatic cancer, or when the time they were told there was really no other treatment for their heart failure because their kidneys were failing. And they certainly usually tell me about how it was told to them and where it was told to them. And there's lots of evidence to show that that quality of that conversation affects the ability of that person to then move through the next part of their life. And equally, the other part of that is that the quality of the caring for the dying, there's lots of evidence to show that that has a whole of system benefit for our society in terms of the ability for those bereaved people to make sense and context for the death and to return to being productive members of our community. So, yeah.
And the final question. Thank you.
Hi, Alan Cena. I think until we make communication skills a core clinical skill, like putting a drip in, like intubating or whatever, really communicating in healthcare in an acute environment is very different to everyday chit-chat and requires really, and it can be taught in a structured way, just like we might teach an epidural. There are some structures. And I think one of the commonest things we hear is by patients is they're not listened to, or no one's ever listened to what I've had to say. And I think whether we agree or disagree, I think the hardest thing is actually doing that listening process and learning how we can listen much better to patients and probably our colleagues too. When we're actually delivering healthcare, and certainly, I don't know whether you're involved in any research around that area, but that's my feelings.
So, there's a lot of initiatives around communication, and particularly I can speak about doctors, and the University of Adelaide Medical Program has an extraordinary program of communication, and there's a structured program through the lower years, and a new initiative of complex conversation, assessment, feedback and assessment that's embedded, and then postgraduate programs, most fellowship programs, particularly palliative care, medical oncology, a lot of the other things have even the surgeons have communication. That's a bit rude, sorry. But there are structured postgraduate communication modules across all areas of health, well, for medical that I can speak about, including into postgraduate things. And yet, there are so many examples of poor communication, and it's not just blame the doctors, but yes, they are, and we are all responsible for our communication and the way we interact at a non-verbal, verbal, but it's having the right spaces in ward areas so that you can have those private conversations. It's having the right quiet sort of places. Now, I'm working at Lower McEwen at the moment in these new pods, and yet outside these lovely single rooms there are groups of cleaners who are having a little chat about the meaning of life, and I think they've lost their broom cupboard to go and have a talk to. And I'm not sure that I've actually found the nurses' tea room where people used to go and have a chat anymore. And so there are structural things within the system. I've had several failed grant applications to try and how do you get senior doctors without losing face to be in a situation where they learn and improve their communication skills? And so I've put in things saying, how to cope with the trainee in difficulty. So really you're teaching the old person, the older clinician how to have a difficult conversation when they've got a trainee who's having challenges. So it is a whole systems thing. So it's not blame the one person, but we have to value good communication as health providers, and some of that value is making it a whole making it something that we all want to aspire to, but also sometimes you need to have some hooks along the way, and maybe it is. We have to do them, now it seems the antithesis of communication to have an online tick box process, but there must be some things that we can do to improve that.
And one of them would be to come to a forum like this, because we're all having a good conversation. It's not difficult though. Can you join me in thanking Gregory? And our final speaker is
Koshila.
Koshila Kumar.
Okay, I think the recording may have finished. So. Oh, no, it's still going.
And this is not palliative care, it's not education, but nevertheless.